King, whatever, is applying for this training. So, like, with a group of friends, but others.
Okay, now please.
This is sent around.
All the application goes to Sarah.
I'm sorry, I'm not talking about that. I'm talking about what you just sent one, the Pacific one.
Oh,
I sent the survey to ask whether she knows this, that is beneficial. She just let us know to see if she should arrange for coming on. But she needs to update herself with all this because it's ADOS tool. I know ADOS, but not ADOS tool. So.
Very good afternoon, everyone. Hope you can hear me. Yeah, very welcome to our guest and our panelists this afternoon. I'm going to be your moderator for today. My name is Tan Cheng Yi, and I'm a chartered educational psychologist in a private practice. So thank you for taking the time to join us for this very relevant and important conversation. We have entitled the talk today as Conversations on Mental Health Care of Autistic Adults Level 1 in Malaysia. Now, this conversation conveys a long-standing and widespread disparity in access and opportunity, a systematic barrier and gap in adequate and affordable mental health care for autistic adults. So some people may question the use of this word autistic adults. As we have been taught in the past, to use the word adults with autism or people with autism. However, when we checked, right, we were reassured that the autistic adults themselves prefer to be referred to as by autistic adults, this term, and as it is an integral part of their identity. Okay, so without further ado, I shall begin. First, I would like to thank our host, Brainbow, especially their founder, Professor Dr. Loh Hui Min, and Kasin actually for doing a lot of work in the background and getting us here today. So this is a little bit about Brainbow. Brainbow is an educational and training organization dedicated to supporting children with special educational needs in Malaysia. Brainbow is rooted in research from University Science Malaysia, and the company develops culturally tailored diagnostic tools, conducts hands-on training for parents, teachers, and professionals, and creates inclusive solutions to help all children unlock their potential. Through its suite of innovations, such as the digital screening tool, Lemon, and the reading assessment, Membaca Uji, My Baca Uji, Brainbow provides a user-friendly, evidence-based resources designed specially for the Malaysian context. So with the mission to build inclusion beyond limits, Brainbow bridges the gap between research, education, and real-world practice, empowering schools, families, and professionals to make meaningful impact. Now, today's conversations is a collaboration between Brainbow and Aim High. So I shall now pass the time to Alicia Tui from Aim High to introduce us to the society.
Hi everyone. Thank you, Chingy. Thanks for the introduction. And I'm Alicia here. I'm one of the committee member for Aim High. Just a quick introduction on Aim High. Aim High was launched in 2018 with a group of like-minded leaders who are passionate in advocating for autistic adults. Then in 2019, hi Zamil. In 2019, we hosted the first webinar and some social events as well. And the public engagement is growing since then. And in 2020, due to the MCO, activities is moved to online. And there are many support group is being done for parents, for autistic women, and autistic men as well. Then in 2021, as Aim High grew, it is separated from parent support group so that Aim High can focus on level 1 autistic adult, addressing the special needs for level 1 autistic adult. And then in 2022, we are actually registered under our government ROS as an NGO. This is the first level one around non-profit organization run by level 1 autistic to support level 1 autistic and advocate. So this is the short introduction. Next is next slide. This is some next slide. Thank you. This is some of the past activities this year. Like we have campaigns to draw awareness or for public to know more about level 1 autistic adult. And we also advocate and run social media campaigns sharing stories from our peers on this. Next is also next slide is also about some of our collaborative work. Like for example, today's webinar is thanks Brainbow. We collaborate together. This is also past some of the webinar that we collaborate together with our partners, including Brainbow. Next. If you know any of your friends or families who are level 1 autistic, feel free to share with them about Aim High so that we can get connected. Next slide. Feel free to share with them about Aim High so we can get connected and support each other. Without further ado, I pass this back to Ching Yi Thank you very much and enjoy.
Thank you very much, Alicia, for that introduction. So before I introduce our panel for this afternoon, let me say that we have prepared a platform for you to ask questions. So you can scan this QR code, which will take you to a Slido where you can type in your questions, and our team will compile the questions so that we can ask at the end. I would like to make sure that we also keep to time. So we might not be able to answer all your questions. And I would like to stress that today's topic is on mental health care barriers and gaps. Therefore, we should stay within the topic so that we can really focus on the key issues related to barriers and gaps in mental health care. Okay. So let us now bring our attention to our panelists for this afternoon. And so I'm going to introduce the four of them in no particular order. Our first panelist is Miss Eunice, who is a clinical psychologist, a supervisor, and adjunct senior lecturer for 2 master's programs. She holds a master's in clinical psychology and is trained in CBT, EMDR, play, and Zen play therapy. She's the founder of Passion Hub in Penang and has over 18 years experience providing assessments, diagnosis, psychotherapy, and trauma-informed support for neurodivergent individuals, promoting their emotional well-being and inclusive care systems. Next, we have Dr. Diana. And Dr. Diana is a consultant clinical psychologist and founder of Flourish Life Psychology and a visiting consultant at Selesa Pacific Hospital in Miri. She holds a doctorate in clinical psychology from the University of Queensland with her 15 years of experience in Australia and Malaysia, including her work with the Autism Association of Western Australia. She supports individuals and families in mental health and special needs. She's also a speaker, trainer, and co-leads Empower Special Needs Connection, MIRI. We also have with us Dr. Lai Feng Hua, who is a consultant child and family psychiatrist, graduated in medicine and psychiatry from University Malaya in 1987 and 1994. Dato completed specialty training in Oxford and served as a consultant until retiring in 2019. Qualified in cognitive behavior and family therapy, Dato runs a multidisciplinary practice in Penang, and as Vice President of Penang Medical Health Association, Dato continues to promote mental health awareness. Last but not least, our final panelist is Dr. Aminah Kasim. She was a consultant child and adolescent psychiatrist. She holds a medical degree from USM and master in psychological medicine from UM. She has an MSc from King's College London and qualifications in Islamic counseling and homeopathy. With over 30 years experience across Malaysia and the UK, including her last post at Hospital Tunku Aziza as a consultant, she now consults part-time at NH EduHealth, continuing her commitment to holistic mental health care. So to help us follow the conversations this afternoon, we're going to use this structure as a guide. So we will have a flow. Maybe we can have the next slide first. Thank you, Kasin. Yeah, we will look at understanding the barriers in mental health challenges among autistic adults. We want to address the stigma and misconception that people have about autistic behaviors. And we are going to examine, talk about whether the current mental health settings are adequate to prepare to support them. And then we also talk a little bit about accessibility and affordability of therapy options. We move on to identifying the gaps. We want to differentiate autism from mental health disorders. Then we ask the question to probe the systematic disconnects between their needs and the support that is available out there. And finally, we'll also like to touch upon finding the right mental health professional. And finally, of course, we would like to leave us with thoughts about how we can all collaborate and come together to action, to put these into action. So that's building neuro-inclusive practices in mental health care. And what can we do in the short and medium term so that we can have long-term effective impact for our adult autistic level 1. Right. So I'm going to turn to the panelists with the questions, but before that, just a quick, just help us to understand the issues that we are facing for our conversation today. Can I have the previous slide, if you don't mind? So autism is a broad spectrum of neurodevelopmental differences characterized by social and communication challenges, repetitive behaviors, sensory issues, and unique strengths and differences. And we do know that it is a lifelong developmental condition, in which case many mental health care providers, doctors, psychiatrists, counselors would come in contact with someone who's an autistic adult, level 1. And level 1 autistic adults experience significant mental health challenges, not because the autism is mild, but because their needs are often overlooked and unsupported. And autistic adults tend to use the emergency department for mental health related conditions disproportionately more than non-autistic adults, yet they continue to experience unmet mental health care needs. So the first question, I'm going to turn to Dr. Lai to answer our first question. What are the main mental health challenges that are unique to the autistic adults? Can you tell us a little bit more? What kind of mental health challenges are we talking about here, Dr. Lai?
I think as any other, just like neurotypical people, autistic adults will do suffer from similar mental health illnesses such as depression, anxiety disorder, schizophrenia to a smaller extent. But particularly, I have seen that PTSD tend to be disproportionately higher among the mental health problems in autistic adults, probably due to their memory system, which is more sensitive. They tend to remember things more, and the memory sort of gets stuck in the brain. So I've seen many cases with PTSD among the autistic adults. Also, they tend to have more adjustment disorder with different types of anxiety mode, depressed mode, because of the social interaction that they have difficulties in, whether in school, in university, or at work. Yeah.
Thank you, Dr. Lai. So I wonder whether Dr. Diana would like to also add on from a perspective of a psychologist. So far, Dr. Lai have talked about PTSD and adjustment disorders. Yeah. Could you carry on with a bit more?
Sure. Thank you, Cheng Yi. Within the psychology practice and the years of seeing different ones with autism, we have come to encounter lots of really amazing autistic children and adults, obviously. However, within the clinic settings, there are 5 key areas that I see more pertinently. The first one is this aspect of chronic misunderstanding. Lots of our autistic adults or teenagers and children are often misjudged, misinterpreted. So, for instance, issues of communication, play, and social differences are misread as intentional rudeness, lack of empathy, and things like that, rather than neurological variations. And so the society tends to see things from a very linear perspective. They assume that, a developmental, presentation of a person is as such, and therefore everything else should be linear. However, there is a lack of understanding about neurodiversity as such. So people then tend to expect that, well, if a person is this high IQ in science or in chemistry or in art, they should be able to speak this way as well. And when someone doesn't meet those societal expectations, people might then assume that this person is intentionally, that is their character of being difficult and things like that. So over time, the repeated misunderstandings and invalidation, I would say, impacts a person's identity. As we do, we would feel that way too if we are constantly being bombarded as such. Yeah, so this affects the confidence and things like that. Second aspect that I see a lot would be individuals, with neurodiversity, autism particularly, tend to have really, really high anxiety. Many of us would agree with that. And, it could be due to anticipatory anxiety before things are happening, there are changes, unpredictability, transitions are really tricky. Social interaction pressures as well, right? The fear of being misunderstood or making social mistakes makes a person feeling on edge very often. Yeah. And all this accumulation of, prolonged anxiety and things like that leads to overload of sensory, cognitive and emotional, state where it triggers shutdown and meltdowns. Yeah. The other thing that comes up a lot would be aspects of social and micro traumas. What does this mean? So we hear from lots of our teens and our adults who, in new schools or even in universities, there's just accumulated years of sometimes, being unable to, get into certain friendship groups or even aspects of teasing or being bullied, sense of rejection, and even huge traumatic events that come up across the years. And so, as what Dr. Lai mentioned just now, add that with strong memory as a superpower, those events seem to be very, very fresh, as if perhaps the traumatic event might have happened in early childhood, but for an autistic adult who have strong memory, those things might feel still really strongly even years later, and that adds on to the trauma that the person experiences. Then we obviously know about autistic burnouts as well and depression, which really reflects a sense of deep exhaustion, right? Many of our autistic adults have, feel like when they go out to the community, there's a sense that the masking that needs to take place, suppressing certain steaming behaviors, trying to fit into the society, hiding sensory needs, especially when the society doesn't really understand those things. And so this really leads on to deep exhaustion. That is tough, really tough. Yeah. The final thing that I want to highlight would be this aspect of chronic low-level sadness. So, over the years, we've supported lots of children and adults, and even though many of them have overcome certain sort of acute depression and things like that, what I then notice is that across the years, even when things seem quite good, or when I say good, I put it with a bit of a there's quotation marks. There might not be big triggers at that point, but the autistic adult would still be sharing that, I don't know, doctor, I still feel this low-level sadness, even though nothing particularly is triggering me. And so what we put it down to would be potentially that sense of, accumulative stress that has, built up across the years. And so a person tends to feel, numbness, difficulty in still that sense of unsettlingness that leads to the depression. Yeah, so those are my 5 things to highlight, Cheng Yi.
Yeah, there's definitely a lot to highlight, isn't it? And I think particularly what you said at the beginning about the mismatch between maybe what a parent know about a child, and then actually when the child goes into a mental health setting, a new unfamiliar setting, their first impression is really not always what it seems, isn't it?
Yes, exactly right.
So thank you for explaining all that. I think that was really so comprehensive. But we're going to move on to I'm going to ask Eunice, who's also a clinical psychologist, to answer the next question. Yeah, let me have the next question. There's often misunderstanding around autistic behavior, which we have just heard just now, and many people see meltdowns in particular as a bad behavior, right? So we hear of these in our clinical practice, kids being labeled as behaving badly. So how can we help shift this perspective?
Thank you, Chingy. Yeah, when we talk about autistic behavior, it is very important for us to remember what we see on the surface, the crying, the shouting, the so-called avoidance from tasks and all that. It is often just the tip of the iceberg. What we call behavior is actually the nervous system last form of communication after a long period of internal stress. So maybe we can actually break down where the stress comes from and how it builds up over time. So when we begin with the social communication and also cognitive as well as sensory differences, these are foundation and yet they often go unnoticed and misinterpreted. Autistic people tend to communicate in the way that are direct, literal, and deeply honest. They value clarity, consistency, and also truth more than all this small little talk that imply meanings and all that. They don't read between the lines, they read what's actually said. But there's many environments like school, workplace, and even therapy. This directness is actually misinterpreted as being rude, blunt, and unemotional. And at the same time, in terms of cognitive processing, also works differently. Autistic people minds often show monotropism, a deep focused way of thinking that need immerse fully into one idea at a time. And difference in central coherence, noticing details being before big pictures, and maybe like hyper systemizing, understanding the world through logic, structure, and patterns. These are not deficit, but I see it as like distinct ways of how processing and making sense of information. And at the same time, in terms of sensory processing, works very different. And autistic individuals may hear every layer of sound in a busy room, feel every tap on their clothing, sense tiny shift in the tone and all that. Their body constantly processing in a very high volume of input and all that. Some may see it as like sensory load. And when it happens, you can see that their load are already very close to full. So now imagine we have a person already have overwhelmed in terms of sensory input, and on top of that, they are corrected, they are judged, they are invalidated, and in the way they communicate and all that. And this will actually over time lead to feeling of like feeling unsafe in a social space. And not because everyone is mean harm, but it's just how the brain learn that being authentic often they will lead to misunderstanding or being rejected by people. So that's where masking begin. And when masking is not just a social acting, it's just a survival, the person start observing, copying tone, facial expression, or even body language. Then they start to hide the seeming, suppress their sensory needs, and they try to rehearse in the way that appear normal enough to avoid conflict. And from outside, they look calm, polite, or they are well adjusted. But inside, you can see their nervous system is actually working overtime. Yeah. So this is actually how like Hall and colleague in 2017, there's a research that they found that masking drain cognitive and even emotional energy and create a state of continuous monitoring. And it's also disconnect the person from feeling their own body. Then where we call this as something we call interoception. So they stop noticing when they are anxious, tired, and overwhelmed, because their focus is on like how I want to perform safety rather than feeling safe. So this is actually leading to autistic burnout, and it's like one of these researcher, Raymaker in 2020, they describe it as having all of your internal resources exhausted beyond measure and being left with no cleanup screw anymore. So like burnout isn't like depression and all that, is also not laziness, but it's actually a physiological exhaustion that like I'm living in the world that keep constantly needing me to perform and adapt. So then in a way that the body no longer able to perform,
then they move into something called meltdown. They can even like going into the state of shutdown, whereby meltdown is like I go into that fight and flight mode, that I start crying, shouting, and because my body is like really very tired. And shutdown is like where the freezing and collapse state started, and where someone withdrawn with speech drops, expression flattened, and they appear fine outside, but they are actually totally shut down within inside. So both of these nervous system like protection responses is not a misbehave, but a lot of time professionals see it as non-compliance, and it's actually it's not about uncompliant. It's just my body started to say that I have no capacity left anymore. And that is where we do see alexithymia, whereby they have difficulty identifying, describing their emotion, whereby they have been masking or they have been like emotional detachment for long, that the person, the result of being disconnected from one's own body signal while masking and all that. So in a way that I start to suppress so that I can react in a way that is okay to other people. So when we look at these social communication side difficulties, differences with the cognitive differences, sensory differences lead to misunderstood and all that, in a way that will lead to all this visible behavior. Yeah. So it is very important for us to look into, not to look into writing a behavior plan, but we are looking into how we want to write a safety plan to target the inappropriate behavior. Yeah. Thank you.
Right. Well done, Eunice. I mean, what I hear you say is what the shift should be, that we are looking at behavior perhaps from a physiological perspective first, because when you are anxious and overwhelmed, it just you freeze, right? And therefore, when you freeze, even the words won't come out, and behavior, you don't act rationally sometimes. So I think I like your position of understanding and thinking about behavior plans. I think it comes to mind teachers. Teachers write behavioral plans, and I suppose you're not saying that we shouldn't write behavioral plans, but we should consider first how the behaviors are, first of all, what is underlying those behaviors, so that when we plan, we are actually planning more to meet the underlying needs. Yeah, I think that's really important. I think the next question is really to ask in terms of the barriers that we see in mental health care is, I'm going to turn to Dr. Amina for this. Do you think our current mental health care settings are adequately prepared to support autistic adults, or are they still largely neurotypical in design?
Assalamualaikum and good afternoon, everybody. Thank you, Cheng Yi, and to the organizer for inviting me.
Good afternoon.
Yeah, I think the easy answer will be, yeah, it's still very much neurotypical design. But it makes us think, why is this so? Okay, I think most of us will be more familiar that diagnosis of autism has in ICD-10 or ICD-11 or DSM. But let us look into the history where 300 years ago, this condition were more recognized because children were just eloping, or they just, they were kind of like abandoned. People were finding their kids, don't know from where. And 200 years ago, it became more clear that there are certain groups in intellectually disabled school, they recognize certain patterns of children having certain things, certain behavior that is very much like core autistic. And about 100 years ago, Bleuler come up with the term autism to describe symptoms of schizophrenia. That was how we come up with, we thought that it's schizophrenic, childhood schizophrenia. But actually over the years, over the decades, it has been shown that it is actually a very different thing. It's a very different thing. And Kenner come up with similarly, and in 1944, hence Asperger came up with this observation of children who are different socially, but they are verbal compared to the other groups of the more disabled children. And in the 1970s, I think Lorna Wing and Professor Michael Rutter, I think through their research, they suggested that it is definitely a separate developmental issue. And then if you look into DSM-2, DSM-3, DSM-4, DSM-5, you see the evolution, the understanding of autism change over the years. And that indicate that, it's still like we are still looking that, Asperger is no more in the diagnosis, but we come up with, is it level 1, level 2, or level 3 autism? And then now there is another view of looking at, autism has like having 4 subtypes, where the most common one actually, the one who actually like basically more affected because of social and communication, and then tendency for the sameness. So looking at that, then we can understand why we are very much neurotypical, because even in the fraternity of psychiatry and psychology, it is still evolving. So setting up of services will require us to really look at our understanding about autism, because when we understand better, then we can support better. I think I'm giving a bit more time for our previous speaker and the next speaker. Thank you so much.
Thank you, Dr. Amina. So one of the things we can think about whether we are adequately prepared is about things about affordability. I think that's a really big concern. Are there? So I'll turn to our next question. If you don't mind, I'm going to ask Dr. Diana if you can give us some insight into this. Are there
Yes.
affordable? Are there affordable, realistic therapy options out there for autistic adults?
Thanks for the question, Cheng Yi, and thanks for Dr. Amina's really good background information as well. So this question about mental health services for autistic adults is really a huge one, especially you can turn on to the next slide, please. So the panelists, the speakers, we were actually chatting a bit in preparing for today's session, and many of us were talking about, wow, our heart really goes out to our autistic adults and parents and youth, because honestly there is a lack of mental health support for autistic community in Malaysia. Now, if we look at it, mental health as a whole in Malaysia, to be honest, we already have a lack of accessible support and services. And you add that on top of autism-informed and neurodivergent affirming mental health services is even lesser, right? So it's a double fold whammy that is that we are seeing in Malaysia. Why is that so? I think it comes back to the professional training and also people's experiences. So many of the clinicians might know that even within the area of mental health, whether it's psychological or psychiatry or counselors, many of the trainings are specifically targeted to mental health per se only. Not many actually have exposure or training in the area of neurodiversity, autism care, ADHD, and so forth. Yeah. So lots of the clinicians that, for instance, with the panel here, we come from a place of really special interest. Like we genuinely interested in supporting individuals with on the spectrum because of perhaps the different ones that we've seen before. So yeah, so limited autism-informed services, insufficient professional training, and the third one would be the barriers, access and affordability. So access, we're talking about the locations of different ones. Perhaps there might be more services in KL, the big cities. But what about the smaller towns and the rural areas, especially if we're looking at even in Borneo and Sarawak, very, very limited. Affordability as well. We all know this is not easy. It is pricey, and especially if you're talking about needing long-term support, right? At the same time, I also want to bring up, before I go into the aspects of hope, this is why the call to action is really important. Towards the end, we're going to highlight this, yeah? But I also want to leave a message of hope, because we do see within the landscape of Malaysia that awareness and advocacy is definitely growing. We see a bigger group of people being aware of this. And so support does exist. So our encouragement to all the autistic adults and the families, please do reach out and explore options, right? Because the different autistic youths and adults that we've supported through the years, we do see them thriving. We see it with the right support environment. If you can turn to the next slide, please. So as things that you can consider in terms of seeking support would be reaching out to mental health professionals, and that could include a whole suite of psychologists, counselors, psychiatrists, exploring public and private mental health services. So we're talking about public hospitals as well as private practice for psychological services. Some of the schools and universities that you attend might also have their own counseling teams and counselors available. So that's also a good support that you can access. Not many students are aware of that, so please do consider that. We also want to share about tips for affordability, right? So let's just say you've done your work, exploring, calling up some of the psychological practices near where you live. The next thing that you can then consider would be discussing with them, do they have trainee-led sessions or maybe even junior clinical psychologists? Because sometimes the rates might be a bit different, yeah? Even with the trainees and the junior-led psychologists, you do want to also explore that they do have supervisors that have an experience in autism care. That's really important, so that you can actually get like a double support in that sense. Also explore aspects like sliding scale fees, ask for, if they have any financial assistance, subsidies, and pro bono services, because certain private practice do have that. They don't advertise that, but if you do ask that and explore that, that could be available. Helplines in Malaysia, there are also several like Befrienders, Lifeline, Talian, Heal, and so forth. We could probably send out some of these contact numbers later on towards the end. And of course, adult autism peer support, like Aim High is a brilliant avenue that the autistic adults can connect together. There are some global online communities as well, like within the UK and an Australian system that you can explore. Yeah.
Thank you. Yeah, absolutely. I really think if we don't ask, we don't explore, we might not find out. And yeah, I just wanted to go back a little bit also to what Dr. Amina has said. I think what she shared in terms of the background of the evolution of our understanding of, ASD or autism in general. There's so many changes over time. And I think that also makes it difficult for us to maybe have a collective understanding, and it is not just Malaysia, but internationally, globally. And so this barrier may stem from that. And in terms of the trainings that we get as professionals, perhaps we can move into talking about the gaps now. We've heard so far that things like PTSD has been mentioned, adjustment disorders, anxiety disorders, and depression. So these are mental health concerns that we hear generally. So I just wonder, how do we actually differentiate when it's autism or other mental health disorders? I understand that sometimes, especially as they grow older, as autistic adults, these challenges are kind of masked and merged together. So I'm going to turn to the two medical doctors here. Dr. Lai, could you help us to understand this question? And then I'll go to Dr. Amina. Dr. Lai, I think you're still muted.
Okay, you're talking about how mental illness is presented among
Yes.
neurodivergent population, right? One thing about autistic adults, one difficulty autistic adults, I think maybe on the whole faces is a difficulty in expressing how they feel inside, making known what they feel and what is inside and their difficulties that they are facing. So although they experience the same type of symptoms and that neurotypical people experience, their their lack of ability to share what they feel sometimes make it difficult for psychiatrists, for clinical psychologists to understand what they are going through.
So there's Dr. Lai, they are often misunderstood. There's also misdiagnosis, isn't it, of the mental illness and autism. How do we differentiate when somebody perhaps is turning up for a diagnosis for autism? They want to find out whether they are autistic, but they also have co-occurring mental health concerns or disorders.
Yeah. So I think as a psychologist or a psychiatrist, we probably need to have a broader kind of uh, perception, broader point of view. So someone who comes, an adult who comes to ask for a diagnosis of autism, right? We'll talk to them. We will go through the usual history and also the symptoms that they are having. And yeah, on the one hand, we look at the diagnosis of autism. On the other hand, we also look out for signs and symptoms of any mental illness. When it comes to diagnosis of autism, Dr. Amina mentioned ICD-10 and now ICD-11 and DSM-5. The criteria there are quite clear, and we can actually let the clients have a copy of the criteria. And some of the terms, although we may need to explain to them what it means, but basically autism, we look at three areas, right? The language development, the social development, and this I call it OCD-like kind of presentation, this obsessive, repetitive kind of behavior. And then together with it, there are this sensory input kind of symptoms. So other symptoms of mental illness usually are a result of this difficulty, this neurodivergent difficulties, causing it to be difficult for them to interact with the society. Yeah, so we have I remember a college student who is autistic, but he's interested in a female student classmate. So in the college, he will go around following the girl everywhere she goes until the female student really freaked out and got so scared when they reported to the college admin, and he got into big trouble and he had a meltdown. And so how would we classify this in a DSM? It's more adjustment. It's more the result of him not knowing the usual social norms, what he's supposed to do when he's interested in a girl, and what he's not supposed to do. He shouldn't be stalking her, and areas like this. Usually it doesn't lead to severe mental illness, but it does cause a lot of problems.
Mm.
But there are autistic adults who do have depressive illness, anxiety disorders, just like any other neurotypical people. And when they present with those, then we treat like any other normal person.
I see. Okay, that's that's a good explanation, Dr. Lai. I think what you're saying is as a psychiatrist, you look for both symptoms, isn't it? Because sometimes the mental health issues could be secondary, right, to the primary concern or the underlying autism.
Yeah.
So yeah, and then especially those challenging behaviors when they don't understand how to conduct themselves properly, then that's when they have other problems that come with it. What about Dr. Amina? Can you share your perspective of how autism is often misunderstood or misdiagnosed as a mental illness, and how we can differentiate more clearly autism from mental health disorders?
Thank you, Cheng Yi. I would say that autism basically is a very much misunderstood condition among clinicians, especially the level 1 or the higher functioning autistic adults. And generally, I think the evolving changes in terms of understanding of autism is that it is basically another way of the brain functioning very different from the neurotypical. And then because of that differences of functioning, they are also prone to other mental health challenges like what Dr. Lai has mentioned earlier on. So basically, like, we really need to move towards being able to recognize so that we can support. So it's really like we need more awareness, we need more training for clinicians like me also, because I think it's really like for the last 25 years, a journey of learning about autism and understanding autism to be able to support better. And it reminds me like when I started going into child psychiatry, the group of clinicians in KKM, they were working on child abuse work, they were going around the country to talk about how do you manage, how do you identify, how do you manage child abuse cases. And I think perhaps similarly, we should be doing something like this so that we can start creating changes, even though like it will still need a lot more to be done. But that will create, that, yeah, we need to do something. Then it will also create the needs to develop more of the multi-agency, multi-ministry work. Because it's not just about a parent, it's not just about a doctor, it's not just about a hospital, it's not just about a school, but it really requires a lot more collective work. Thank you.
Kingsley, can I just add something?
Sure, go ahead.
Yeah. Talking about affordability, actually, under the Malaysian government, the Ministry of Health, there is a new group of specialists that a lot of people in the public do not know. They are called the family medicine specialists. Okay, and they are like GPs, the general practitioner, but they are specialists, so they actually know more than ordinary doctors about different areas of life. That includes psychiatry and even child psychiatry. They know a bit more than ordinary doctors. So, and they are located where they work. They work in KKs, Clinic Kesihatan, which is found all over the country. The big health clinics. So nowadays, Clinic Kesihatan, they have at least one. Sometimes they have 3 family medicine specialists. So they are good people to go to for adult autistic adults when you have problems. Don't have to wait for for months to see a psychiatrist in a general hospital. Just go to your nearby clinic kesihatan, ask to see a doctor, and then later on request to see the FMS, the family medicine specialist, because they have gone through psychiatric training before. They have also gone through pediatric training, so they know a bit more about autism, about psychiatry. So they are a good group of doctors to go to. And if they can't handle your case, then they will refer you to the psychiatrist in GH, and their referral will usually is faster. It reaches the psychiatrist faster. And you only pay RM1 to see them.
Oh, that's a very good tip. Thank you for that signposting. Yeah.
Okay.
So I think what we've learned listening to the two of you is also the fact that you may know the criteria like in the DSM or ICD-10, but actually how in real life it plays out is something that perhaps a bit more experience and trying to look beyond the behavior that is actually presented, right? And that goes back to what Eunice was saying earlier. Then we don't quickly judge, what we see as the behavior, but try to understand what is causing the behavior, the physiological, behavioral, and cognitive thinking behind it. Okay. I think I can move on to the next question, unless anyone want to add anything, any of our panelists want to add anything more to what we've said so far. Okay, we'll move on to question 6. So we're going to turn to the two psychologists for the next two questions. So I'm going to ask Eunice, where do you see the biggest disconnect between, what autistic adult needs and what the system currently provides?
Yeah. When I think about the biggest disconnect, I often go back to something the late autistic advocate Donald William once said. Yeah, I think we need to move to the next slide. Yeah. Yeah. Probably the next one. Yeah. All right. So from the time the word autism was coined, it has been defined by its appearance, not by how it is being experienced. The sentence really captures exactly why so many autistic adults continue to feel unseen within our current system. Most services where our mental health services, even education or employment are still built around how autistic looks, not how it feels. Professionals are taught to observe behavior, whether the person have eye contact, body language, whether the person behave in the expected behavior, but rarely taught to listen to the internal experience behind it, the sensory processing differences, the anxiety, the masking, the fatigue, or even like the burnout. So, and is where the first gap begins, when it's visible to us that what is lived by them is also very important. Yeah, probably we can go to the next slide. This is also like what Verdant 2024 actually remind us, like when we are looking into what is being disconnected, what is evidence-based practice. It is not only like about research, about true evidence-based practice, but it's also looking into clinical expertise, yes, and also it's very important where the client and carer own values and experience and their needs that we need to look into. So when we only focus on what can be seen and measured and outward the behavior and also the progress chart and all that, we fall into the same trap that Donald Williams described, define autism by its appearance and not how it's being experienced. So we can see like in terms of the system-wise, like many like traditional social skill program being widely used, they look into effective, like in terms of paper, yeah, and with research, yes, they are very effective. But they didn't actually look into the differences. When we are listening to autistic adults, many describe those same programs are very exhausting and very identity erasing, whereby they train a person to appear typical, normal in front of people, rather than I'm feeling safe and connected within. And we need to actually ask ourselves like these two questions when it comes to a lot of all this evidence-based approach. we need to look into, does this intervention build safety, regulation, and self-understanding? Secondly, does it simply train someone to look acceptable while remaining disconnected inside within? So this come to the second gaps that I can actually see is more towards a sensory safety. So most of the environment, classroom setting, even our clinics, office are designed for neurotypical sensory system. But autistic people process the world through different sensory wiring, not just over sensitivity or under sensitivity. There's actually a lot more that have been shown in research. So those are the part that we really need to look into, whether our clinic is safe for their body. And it's not about whether we are actually working on it or not, whether is that because like what we did is lack of effort. It's actually poorly designed in terms of environment for their body. So sensory safety is very important, and it helps the body to feel safe, and we can open up communication and growth and make the therapy progress differently. And the third one is actually I can see the gap is more in terms of fit to succeed myth. So like you can see like across the system, we can move the next slide. Yeah, across the system, success is still defined by conformity, by how well someone can mimic neurotypical behavior. Autistic adults are often told to make eye contact, you have to smile, and you have to blend in, and behavior that prioritize performance over connection. So, and while this it may help someone pass occasionally or socially, but they did not help them belong. And this belonging and it's not compliant is what protects mental health. So when masking become lifelong survival strategy, someone lost connection with their own body cue and it stopped noticing hunger, fatigue, and stress. And this is why it's very important for us to look into what is this like for their in terms of their interoception. So, and Kelly Mahler, in terms of their interoception curriculum, really targeted it. This is why instead of actually we are looking into matching emotion, we are looking into how I feel within my body. And we stop looking at like how I want to behave, appropriately expected behavior, but we are looking into energy awareness, how my energy moves now, how I wanted to regulate my energy. Those are actually widely described or even being introduced by a very well-known program, which is something called Autism Level Up, which I personally felt professionals can actually refer to it. So in terms of like it is very good like when we look into what a neuro-affirming guide by Scotland push it beautifully. Authentic social growth begin with when emotional safety replace social performance. And the fourth gap that I can say that is actually we are looking into the support that we are not looking into self-understanding and acceptance. So the next slide, please. So it is very important that we look into self-understanding because they need to understand how their body are, how my sensory system and pattern like, how my energy rhythm like, how is my communication style like, and what is my emotional trigger. All those is very important because self-understanding lead to self-acceptance. Self-acceptance lead to self-advocacy. And when a lot of autistic individuals that I can see, like they told me something like their painful beliefs, such as my need doesn't matter, I'm only lovable when I hide my real self, or I'm not good enough as I am. And this led to what I heard from one of these 14-year-old autistic teenagers that I met a few days ago. He had been engaged with multiple suicide. And he told me something like that. He looked into my eyes that day. He said, Eunice, I'm so tired when I was asked to cope or change for the world. This is what our system are for our autistic patient now, that expecting them to fit in by changing their own identity. And we need to teach them how to understand their body, what their needs are. Then only self-acceptance can happen. And this is how, when they can accept themselves, then we can target the mental health rather than we are asking them to cope and suppress their need to fit in into the world. And I would like to end this. The greatest disconnection is not the absence of services that I can see now. is actually the mismatch between how systems define progress and how autistic adults experience safety and belonging. True evidence-based care and how Jordan told us and remind us must always include life experience, and true inclusion happens when autistic individuals can understand themselves, accept themselves, and advocate for what they need without fear of being too much or not enough. When sensory, emotion, and relational safety come first, learning, connection, growth become naturally, and thus we stop managing behavior, managing autism, and this is where we start how we care and we nurture the humanity. Thank you.
Wow, thanks, Eunice. There's a lot to process there. And I'm just reflecting. I mean, yeah, I think the idea of safety is something that you have emphasized throughout all your sharing. I'm just thinking like, truly in our emergency services, schools and university is always quite chaotic. So this idea of safety is not easy for the public spaces to create for our autistic adults. And so this idea of having self-understanding, I think that doesn't just apply to autistic adults, but all of us. I think if it takes a long time for the whole public space to become to be able to provide this kind of safety. I think this is ideally, I mean, of course, we would love to get there, but it will be a long time. But I think this self-awareness of each one of us, as we are the people serving the autistic adults who come across them, we can also do our part, right? In perhaps ensuring that we have this compassionate and understanding approach when we deal with them. I think that's what I got from listening to you. And yeah, and I wanted to ask Dr. Diana the next question. I think this one we really struggle with. Many autistic adults struggle to find the right mental health care provider. And this is often a question that we get from them. And what should they look out for in a professional who truly understand and support their needs? We're also mindful there are many, we have people from different states here perhaps listening in. So we look to you, Dr. Diana.
Thank you, Jackie. In terms of what to look out for, right? So a few key things that's really important. I think the first one that we want to mention is that autistic adults, as well as children and teens, we want to recognize that you are the experts of yourself. That's a really important aspect to first realize, because usually within whether it's school support settings or mental health settings, there's an agenda from people outside trying to say that you need to have these goals met, you need to work on this and that. But rather than having all these outside voices clouding it in, the first thing that we want to say is trusting your own feelings as well, your gut feelings, and what actually matters to you. Getting that and knowing that we stand with you, because we get it. The system is really tough, where hundreds of people are trying to put forth their own goals. The teachers might say you need to work on these skills, staying and attending in class, and the speech therapists might be talking about communication goals, and then the OTs might be talking about something else, and adaptive skills. So recognizing your own say is really important as the first step. Now, the other things to look out for then is, as you're exploring which clinician to engage with, 3 key things. First, perhaps looking at their level of experience and competency, whether they actually have experience in supporting neurodivergent adults. Yeah. So what we do see within the clinical settings nowadays is that quite a lot of clinicians tend to come from very mainstream mental health support only, right? So for instance, if a person presents with anxiety or depression, if a clinician doesn't have much experience with neurodiversity, they might just treat it as, okay, we're just going to work on behavior activation strategies, some coping breathing techniques, and work on challenging that person's unhelpful thoughts, cognitive restructuring alone. While those skills and techniques are obviously evidence-based, are incredibly helpful and important, I don't think it's comprehensive enough to support individuals on the spectrum without understanding and appreciative of the individual's uniqueness and the way processing of sensory communication and all that are. So it's important that the clinician has a good grasp of the underlying neurodiversity, right? So for instance, aspects like I've seen different ones that came into the clinic that they've talked about they've been accessing services for a few years and working on certain skill sets, but because it was very mainstream in terms of just purely mental health alone, the clinician have totally missed out in other aspects of supporting the individual. Whereas when we started working on, okay, right, now the anxiety that is popping up, the depression that's popping up was due to other things like handling group work in assignments in university, was due to difficulty in making and maintaining friendships. If the clinician is able to then work through those skill sets as well, working through dynamic issues and things like that, and also being able to customize those sessions to support the individual's communication goals. For instance, looking at visual support, sensory design, redesigning the environment, building up the stakeholders' understanding, that can be incredibly helpful. So the individuals that we've supported, when we look at it in this more comprehensive view, they have actually thrived so much more rather than we just looking at it from one particular angle. Yep. The other aspect that I wanted to highlight as well that's really important is, on top of the experience and the competency, is looking at the clinician's heart. I think that's super important. Making sure that the person that you are speaking with, that the individual has genuine care and respect towards you, right? That when you're with them, you feel safe, you feel supported and seen, right? So how can we do that? Some tips that we would like to share is, even as you're exploring different clinicians to work with, maybe in the beginning, making sure that you actually communicate with them, sharing your preferred way of communication, your preferred way of engaging. Don't be afraid to do those things. Sometimes I know certain autistic adults say that, I feel shy. I don't know if I'm is it okay for me to say these things? Of course it is, because that's what make you incredible. That's what makes you unique, right? So feel free to share. Don't be afraid of those things, so that the clinician can understand you better. Right? And then the second thing, then give yourself permission, time and kindness to explore if it's a good fit, right? Not all of us are going to be, really good fit with each other, and that's totally okay. We don't have to take it personally. So maybe giving a few sessions to try it out first. And if after a while you find that, I'm really just not meeting it, then feel free to say, okay, I'll explore another person, because there is a person out there who will be suitable for you and your household, right? Of course, if at the first session you already find that this person is really, really, unsafe, is disrespectful, then feel free to disengage immediately. Trust your gut instinct. Yeah, that's where I'm going to put it at. Back to you, Chingy.
Thank you for those very helpful tips, Dinah. And so we've actually talked about the barriers and the gaps. Could I have the next question, Kusin? And now we want to move on a little bit to the call to action, right? We would like to leave with, at least, as Diana said earlier, some hope, and all of us listening, some things that we can each do in our own areas of whether you're a parent, teacher, or also a person who has autism. So my question that I'm going to direct to the panelists is, starting with Dr. Lai and also to Eunice, is how can mental health care providers better equip themselves to recognize and support autistic adults with co-occurring mental health challenges?
Maybe to give you some hope first.
Yeah.
Am I muted?
No, we hear you fine, Dr. Lai.
Sorry. Okay. 30 years ago, when I first came up to Penang, to work as a psychiatrist, right? We had only 2 psychiatrists in the general hospital. And these 2 psychiatrists, government psychiatrists, covers the whole state of Penang, right? Island and mainland. Sometimes we have to cover the northern states when they go on leave. So each state we only have 1 psychiatrist 30 years ago. And compared to now if you go to Penang General Hospital, you have easily 5 to 10 psychiatrists and a few subspecialists like a child psychiatrist, forensic psychiatrists, and there's so many medical officers and many of them doing training to be psychiatrists. And this is only in Penang. So in every state, the numbers are quite similar, right? There are a lot more psychiatrists now in each state, a lot more medical officers, a lot more people training to do child psychiatry and different. So the situation is actually much better now compared to 30 years ago lah. This is similar in Sarawak and Sabah. So so if you have a choice, I mean, it's better to have autistic disorder today than 30 years ago. What I'm saying is, right, you have a lot more help now. Although the help may sometimes be difficult to get, or when you get it, it may not be as what you hope it to be. That can be improved lah. So what I feel we can improve is maybe in the training area in universities that are training psychiatrists, we could suggest that the component of dealing with autistic patients, autistic adults, be included in the curriculum, while training psychiatrists. So that will be a good thing to do. Now there are actually 5 or more local universities that train psychiatrists. So a lot can be done. So we are talking only about psychiatrists now. There are also universities that train clinical psychology. So in the same way, we can request that they include this as a curriculum. How clinical psychologists can better work with people on the spectrum, yeah, and communicate with them. Okay.
Surely we can. Yeah. Thank you. Eunice, what about you?
Yeah, I think the first step isn't adding more techniques, but I felt that how we want to shift the lens. This is what I'm looking at. And shifting the lens to a more neuro-affirming approach is start to believe that brain differences are natural, not deficit. But whoever in the Zoom today or in the live stream today, I think it's more important for us to start from us to shift our way of how we look at autism. And there's no right and wrong way in terms of how brain function. There's differences, just the differences in terms of thinking, learning, and how I feel. And it's just simply the human diversity. So instead of how do we make autistic adults fit into the system, we are asking how do we make our system flexible enough to fit them as well. And it starts with all the professionals here today, that we start like a small little glimpse of light, and when we start changes and it have accumulated to become really a spotlight. I see that. So this is very important. Start with safety, not behavior. And many autistic adults enter the room and they all carry a lot of years of social trauma, being told to act normal, try harder. If you look at the behavior, it's actually the anxiety that we have mentioned just now. So we need to look into the polyvagal theory, which is actually the next slide, that we need to understand those behavior reflected stage and how we wanted to help them feel safe to move from freezing, flight and flight response back into social engagement. And this is how we want to incorporate in our services. And we need to equip by reading more about neuroaffirming, about polyvagal theory, about how autistic cognitive differences, sensory differences, and how those stuff are when we are supporting them. And the second one, integrate the body and sensory experience into our daily, our work with autistic adult. The next slide. So, which means like we are looking into, we need to focus not only on thought, emotion, and all that, and we need to look into the sensory processing differences. And we need to work with occupational therapy because 90% of autistic individuals experience sensory processing differences. So this is very important that we need to work with the occupational therapy, and we need to include those like whatever that I mentioned, Kalimala interoception framework, autism level up, kind of like energy meter that is actually designed for autistic individual, not the how the neurotypical people think it fit for autistic individuals. And when client can understand their body, then I think the regulations, trusting begin to form. And the third one, I felt that is very important to work in the multidisciplinary team, whereby we are not a solo provider and we need to have discussion, cross discussion among professionals. OTs, speech therapy, psychiatry, psychologists, and all that, we work in a team. And we together, we share neuroaffirming language, and we assume differences is not deficit first, and it will help to align, like the professional help to align around safety, regulation, autonomy, and we respect autistic adult experience, and this will help with how we provide services. And I think it's very important for me, if I still have a little bit of time, to address that a lot of professionals comes to me, they mention about neuroaffirming approach means no boundaries, which I totally don't agree with it. Boundaries still exist. It's just co-create through safety and predictability, not imposed through control. And structures and limits are vital, but they must feel collaborative, not corrective, when we are actually running our clinic with them. And it is a difference between you must do this and it become here what will help both of us feel safe. How we can find the middle ground that we both can stay in this room and we both can stay in the world safely and we both feel comfortable. So any misconception with another misconception about neuroaffirming care, we are expect the world to fully adapt to the individual, which is not true at all. In the reality, it's about mutual adaptation. Both the person and the environment adjust to meet in the middle. So we provide accommodation and flexibility, so autistic adults don't have to mask and collapse, but we also help them to develop tools to navigate a shared world safely and authentically. That means the middle ground are. So this is very important for the next slide. So competence isn't about managing behavior, it's about listening to life experience. Our goal isn't to help autistic individuals or adults survive in the unsafe system, but it's make the system safer to autistic adults. So it starts with what we do in our clinic first. Because if we don't start it in our clinic and we are expecting the world to change, it can't. They need to start being understood first, and they need to feel safe in our clinic first before we can actually work with what in the system are. Yeah. So this is very important that when we move from compliance to cooperation, from fixing to understanding, we stop trying to change who they are and we start building the space for them. So I would like to end like what I'm sharing about what we can do. Yeah, the cognitive shift. To one of my adult patient once told me something like that. Your logic is different from my logic. When I embrace your logic, it makes my life easier. So it means their logic is different from us. So when I embrace means I still maintain my identity. And at the same time, you are introducing what is this neurotypical world are. And we both find a cooperative and we both find a way that we both feel safe. Not like you are actually telling me, I'm not okay. I need to put down every of my thought and my authentic or my identity to fit in. but more into I maintain my identity and I embrace whatever that actually suitable for me, and it makes my life easier. So that's not to me, it's not what neuroaffirming word really means. It's not like forcing the sameness, but we are just trying to find identity, understanding within the parties and how we can stay safely together and we respect each other. Thank you.
Thanks, Eunice. So yeah, there's a lot shared there. I think we really need to learn to understand one another better. I have got one last question for the panelists before we go to the questions from the audience. In fact, we've got lots coming in already. Yeah, so one last question. Finally, what one key change would you like to see in how we approach mental health for autistic adults over the next 5 years? And because of time, I'm just going to ask Dr. Amina and then Diana.
Thank you, Cheng Yi. One key change would be better understanding, because with better understanding, then we can provide clearer and better support. Just want to acknowledge also, centers like Calvary Victory Center in Johor, Dr. Hasna Toran from the Genius Kunya, and Dr. Amina B. Muhammad Kasim, who actually almost 25 years ago, they were the people I learned about autism and make me view that if this can help autistic children, it would definitely be able to help neurotypical children. You know what they were doing? It was really so much with so much of passion and understanding, and really working very hard. These are like, work that started way decades ago, but it's still not enough. But just an example for what they have done. Dr. Amina B actually trained the nurses in the clinic kesihatan. So the nurses were able to pick up autistic features compared to GPs or even doctors or even psychiatrists, because they were trained. So it's really about, creating more awareness, creating more training, so that giving more exposure. Oh, we can do that. Oh, we can do this. And that atmosphere need to be an atmosphere of learning, of understanding, of love, of compassion. And I think we will go far, because I think looking at all the things that has been happening nowadays, there's a lot, but definitely there's a lot more that we need to do actually. Thank you so much. Thank you so much.
Thank you. So I hear you say the frontliners, right? We need to train the frontliners. So they
Everyone,
recognize.
even
Yeah.
the police,
Yes.
Yeah. Our don't miss out our JKM officers, our school counselors, it basically everyone, the bus driver.
Yeah. Thank you, Dr.
Everyone.
Amina.
Yeah.
And Dr. Diana?
Right. Thanks, Chingy, and thank you, Dr. Amina, for that wonderful sharing as well. For me, I think two important things that we want to look at. The first one would be changing from the landscape of, as we mentioned just now, the aspects of wanting to change a person or to force a certain mold a person, and shifting that to a perspective of understanding and supporting that person. And how that can happen, I believe it's time for us as a society that we have to take ownership that each of us are residents of this world, and we should take ownership in making that shift in the landscape wherever we're at, whether we're in our hospitals or clinics or schools or universities. We can't keep just waiting for someone else to change, or someone, it's the autistic person that has to change, or is the clinics that have to change. But each of us actually play a really key role if we want to see our world actually become more inclusive, right? So taking ownership and believing that it can happen. In my mind, I hope to see that. I can see the aspect of us moving together. And if we were to link our arms together, then flourishing with autism can actually be made possible, right? So shifting that language, that each of us want to build that bridge of meeting in the middle. I like what Eunice said just now, instead of you versus me and whatnot, us. We are all in this together. I believe we are here today, this afternoon, because we love someone with autism, right? I do. And I'm sure many of the panelists and their families and the individuals here adore and love our individuals as well. So together, I think we can really shape this. The second thing that I would like to also highlight is the call to the clinicians. So just now we talked about the multidisciplinary team. I think it's also really important as clinicians, we need to step up in upholding this transdisciplinary approach. What this means, back then when in Australia, we held on to this a lot. Instead of us just looking that I only know about psychology, or another person only knows about OT, the other person only knows about this thing. Clinicians, I believe we also have a call that we can step up further, right? One, having the heart, and two, also understanding a little bit more about all the other important areas that supports the individual with autism. Because the uniqueness of autism is that it's not only one silo. It's not enough for us to only know about anxiety treatment alone, but we totally don't understand about the social communication aspects or the sensory aspects. We have to know that. Then we can actually come from a very comprehensive and holistic views to support the individual, so that families are not left running around. I've spoken to lots of parents and a lot of autistic children and adults who feel like they have to run from between places to places, but there is no coherency. Yeah. So if we can all, as clinicians, step up with our heart and also our mind, I genuinely believe we can shift the landscape to make it a more inclusive and loving community for our autistic adults. Thank you.
Well said, well said. Thank you, Dr. Diana. In fact, I want to thank all the panelists here for their wonderful answers and helping enlighten us this afternoon on this topic on barriers and gaps in mental health care. We don't have a lot of time for questions, and I do want to say ahead of time that our panelists may need to leave, but we'll try our best because there are two questions that have come in, and the team have actually highlighted a couple for me. And I think if the panelists can help me answer this question. The first question is actually about the use of AI, and I think that's very relevant. We have heard about people with autism, autistic adults turning to AI because they do not have access to services. So I think the question here is, how can they use AI safely and ethically? Does anyone want to take that question first?
I have a few, I came across a few clients who are autistic adults or teenagers who, there was once I asked the teenage girl, are you seeing a counselor? He said, no. Then I was thinking who to refer her to. Then she told me, oh, I use ChatGPT as my counselor. I said, does that work? He said, yeah. The good thing about ChatGPT is it doesn't scold you, it doesn't criticize you, it doesn't point out your errors. It goes with you, and so she's very happy with that. But I have to remind her that ChatGPT is not human, it's a machine, so don't follow everything she says. Certain times when you are not sure whether it tells you is true or correct, just check with your parents to make sure, before following what it says.
So listen, but then check in with others, real people.
Yeah.
Right. Anyone else from the panelists? Just one other. Want to add anything to that? Okay, thanks, Dr. Lai, for that. I also have a question about that. This is a recurring thing, and I get that quite a lot as well in my practice. This idea that the young adults, whether in the workplace or university, sometimes withdraw from crowds, from people, because especially during break times. So the question comes from this question is phrased like this. May I know, is it common for autistic adults to just avoid talking to others and avoid activities like having lunch together? Perhaps one of you might like to give us an insight. I see Eunice respond.
That's a very common experience, yes. It is important to understand why it happened, what is happened. For many autistic adults, avoiding social interaction like chatting, joining lunch isn't about disinterest or arrogance. It's often about energy regulation and safety. Social interaction can be very demanding, not just emotionally, but neurologically. They may need to process multiple layers at once, the background, the noise, the body language, the eyes contact gauge, and also the pace of the conversation, the smell of the food, and even like the jokes and the small talk during the conversation. So often works on or during breaks, the person may simply need quiet space to decompose, not because they don't want connection, but because they have already used a lot of their cognitive and sensory energy to function socially. So we call this as social fatigue and autistic burnout, and it's a self-protection and response. So the most helpful approach isn't to force participation, but to create a low pressure, safe opportunity for connection. This is what I think. Like for example, we can allow people to join in their own way, sitting nearby, listening without having to speak, or sharing a structured activity rather than open conversation. So that when social safety and predictability increase, engagement tends to grow naturally. So I think it is common. It is not avoidance because of those emotional sense. It's just a self-regulation in a neurological sense lah. This is what I think. Yeah. Thank you.
Thanks so much. Yeah.
Another reason is there,
Go
there
ahead,
are
Nikolai.
there are some not every classmate or every schoolmate are good people. So that we get some rascals sometimes who they know that you have this social disability. They will purposely bully you in that sense lah. They make you feel foolish. They make you feel bad in front of people. So sometimes that causes the autistic teenager or adult to not want to engage.
I see. Okay. I'm going to ask one more question before we go. This question is phrased like this. How do you help autistic individuals to overcome, especially when they have difficulty with expressing or understanding emotions? I mean, this is where they find it difficult to communicate their needs, I suppose, when they are to others who need to know them. What are some practical tips that we can help them in terms of saying or doing to convey their emotional needs? Anyone? Dr. Diana? Dr. Amina?
Eunice was talking about interoception, right? Maybe Eunice can tell a bit.
Can. So maybe, yeah, or anyone else like want to chip in as well. What
Yeah, I
can
think maybe Dr. Diana has something to say first, then maybe I'll continue later.
Okay, Eunice, you can start first while I'm constructing my answers. Look at how sweet we are and kindly, like letting each other.
So collaborative.
I know, right? Wow, dream team.
Okay, so like when it comes to understanding own emotion and expressing and all that, it start with how I feel in the body. This is why when it comes to a lot of social skill training, when we started with like how someone need to behave, a social rules first, it is actually not very neuro affirming in the sense because we are actually setting up that I needed you to behave in the way that people accept you. But very important is like we can start with something core regulation. We have our target later, but we can start with a lot of activity. That's what I want, how my body feel. So the Kelly Mahler actually have a very good curriculum, like how they setting up people to understand emotion. So they have like activity like how I feel hot and cold. Do I like it? What I feel, which part of my body I feel the hot, I feel cold, like what happened in my body. So it is later on links to emotion. When I'm happy, what happened to my body? Because we won't be looking at the mirror to know that I'm happy now, but I'm angry now. I feel changes in my body. So interoception co-curriculum that we call it with occupational therapy, then they will actually help the client to go into understanding their body first. Then we will slowly move into what is the feelings like. Then we are going into what is your need and how do you feel in the certain situation. So a lot of time in my clinic, a lot of time what I have discussion with my clients that I'm seeing, they will be telling me, they're asking me, oh, in this situation, I'm behaving this and all that. I won't be giving them a neurotypical answer, but I'll be asking them, how do
Melissa
you
also
feel?
knows some.
And what do you experience in your body first? And what is your need first? So we are looking from that perspective. Then after that, I will be discussing about what I think as a neurotypical in that sense, that what I'm going to do, then I will ask them, what do you think if if I wanted you to do this, do you feel comfortable? Then they will not, yes, partly not. So we are going to discuss in the middle, how we meet in the middle, that both side is comfortable. Then he will say, why not if I do this? Do you think as a neurotypical person will feel uncomfortable? I said, yeah, but it can be. Then how do you want to self-advocate for yourself? So the discussion of feeling emotions and all that, you have to come with the sense that how the person feel and need first. And as another things that I would like to add on is something we call core regulation. Core regulation is important in the sense to build up emotional safety, to help the person to understand that I'm moving through different state now. My emotional state in polyvagal theory. So like based on polyvagal, so now I'm actually in my fight and flight mode. So we need to allow the person to go through how I don't feel good, but I'm actually borrowing my nervous system for you, that I'm going to hold the space for you to help you to understand your body needs and how your nervous system are. So core regulation that have been widely discussed, which I think professional can actually read about it, then it actually help the person. I'll start with like, oh, I can see that you're holding your face. Oh dear, you are not comfortable with this. So the person will start to notice what changes in their body. Then this is where we discuss about emotion. I can see this, I can hear like you are signing. Tell me more about that. So we provide that space for the person, not jumping into expecting the person to calm down right away, but we are looking into how to help the person to regulate, to understand what is regulation first. Then we are looking into not trying to solve the problem, but we allow and understand the nervous system is being activated. Then we use the core regulation technique to help the person to allow the nervous system to go up safely and move down safely. And this is how we started to look into emotional safety and all that when it comes to using core regulation and in the setting, the clinic setting. Thank you.
Yeah, I think what you just said may have also answered one of the questions about families, how families can actually, because help, sometimes there's mismatch in approaches. And I think having this communication is two ways. And so if families also can learn to identify those triggers of meltdown, which can be prevented, I think it's a really good place to start before you even deal with any issues. Dinah, did you want to add anything, or Dr. Amina, to that question?
Yes, yeah, thank you, Ching and thank you, Eunice, just now as well. So there's something that I wanted to just add on with regards to what was shared. I think understanding, emotions and communication, it's important to note that there are actually two types of empathy, right? Lots of the people tend to see empathy as a sort of a linear level where people misunderstand that individuals with autism might not have empathy, but that's actually untrue. That's just ridiculous. Obviously, many of our autistic adults have lots of empathy. But so the two types of empathy, one of them is emotional empathy, and the second one is cognitive empathy, right? Now, what we do find is lots of our autistic adults have a lot of emotional empathy. So when another person is experiencing sadness or difficulty or things that's happening, they feel it inside, right? It's the cognitive empathy that is slightly impacted. And what is cognitive empathy? It's the ability to be able to check in with myself and know, all right, what am I actually feeling? And secondly, how do I actually express that emotion that I'm having? Okay, So upskilling on that cognitive empathy is important, because if not, what we see is that the autistic adults are left with huge mountains of emotions that they're really feeling for this friend that is struggling, or the parents that is going through, but they don't know how to process that emotion. So us as clinicians, as a society, as parents, coming to upskill that, I think that's really important. Okay, so that would be the second part, which is building the communication skills then. Right. So if we can increase the amount of social coaches at home and in the school, that will be so helpful, right? Helping the individual say that, okay, you're feeling this. There is actually, how do you phrase that in language form so that another person outside can understand how you're feeling, so that you can articulate those needs, right? The third thing I wanted to say is, how do we navigate this aspect? Because on one hand, we're trying to say it's really important for us to authenticity. We want that. We want to advocate for that, right? Like individuals on this on the spectrum, recognizing the beauty of the neurodiversity. It's not wrong in any way. It's just different, right? And then how then do we also navigate the other part where we say, okay, if I'm going to be super authentic, maybe I don't need to learn all these things, because then I'm being inauthentic, right? So I don't think, as a society, I think we can have compassion and wisdom in this aspect. We don't have to be either yes or no, but we can actually meet in between. So there is a space for skills building in terms of communication and social emotional skills, self-regulation, co-regulation, and things like that. Because at the end of the day, social communication is a choice, right? Our friendships, we want to communicate with a person, is a choice. If we could have those tool sets, structured, systematic coaching on how, I could express myself if, my emotions are high and these things, wouldn't that make it so much easier, that it will be less anxiety provoking, that, I could actually express that in those moments if I choose to, right? But in other situations where I feel like, oh, this is too much, I really had enough of people, I don't want to talk to you, then it's totally okay as well, that you can have those right to say, sorry guys, I really don't want to speak, see y'all, later. Yeah, you don't have to feel forced into it.
Thank you. So, Amina, would you like to say anything?
Thank you so much. I think I've learned a lot from the other panelists today. Thank you so much. I just want to relate that each individual with autism, they are entirely different. Like what Dr. Lai was saying just now, one might not actually go in because they might get bullied, but one actually might go in because they cannot stand the smell of the food, or one might actually cannot go in because they have so much of anxiety. And I think there is so many ways that all of us here can really like create further changes by being the safe person ourselves, keep educating ourselves, keep building up more talks like this, because more people need to hear, more teachers, more doctors, more parents, because I remember having one child who was saying that, when the baby left, the safe person is gone, and that's where there is no safety, So this can happen in the sense that safety can come from so many different people. So let us talk about that. Let us all be the safe person. Thank you so much.
Thank you. Well said. So
Me, one more thing to share.
okay, yes, go ahead.
Recently, I was playing around with ChatGPT. So I said, be my Asperger coach, or autistic coach lah. Then I give ChatGPT a social problem scenario, and then it came out with some good kind of feedback and advice. So the earlier person who asked about AI, you can try using it as autistic coach or Asperger coach for social situation.
Okay, so we be discerning. There are some good things too that we can get from AI, definitely.
Yeah.
Yeah, thank you. Thank you very much to all our panelists and everyone who has actually joined us this afternoon. We are very appreciative of the questions you have sent in, and unfortunately, we won't be able to answer all of them. I think we've just touched the tip of the iceberg, and it has been wonderful to be able to have these conversations. May it be the first of many to come. So we definitely compile your questions, and we'll try and bring you more of these in future. Yeah, thank you very much to Brainbow and also Aim High for facilitating, and definitely to Eunice, Dr. Lai, Dr. Diana, and Dr. Amina, and everyone else who's been here with us. Thank you so much. Goodbye.
Thank you, everyone.
Thank you. God bless. Have a good
Bye.
weekend.
Thank you.
Can I go? Let's see something.
Peng Yi, nursing.
Yep.
Forgot to take a photo. Can we still do it? Dr. Amina still there?
Yes.
And Diana?
If anyone is still here,
Yes, yeah.
Yeah, good. Okay.
Okay.
And who else is there? Cursing? Alicia? Yes,
You
good.
mean the audience as well, the guests, right, Yemi?
Yeah, actually we forgot. So we take the can we do the speakers quickly? Those of us involved in the and whoever is left,
Yeah.
the guests.
You can turn
We
on
are
your
still here.
cameras if you
Cursing,
cannot
can you help?
see.
Yes, I'm trying to look for Dr. Amina.
Oh,
Is she
okay.
still here?
She left. She might have. I don't see her.
Shall I call her?
Yes. Okay. Maybe we can ask her from the chat.
Yeah, I'll call her.
Mm.
Hi, Dr. Amina. Sorry, can you come back or not? We forgot to take photo.
Oh, yes, sir.
Boleh, please. Thank you. Okay. Thank you. Okay. Just for information, Diana, we're
Yeah.
going to be working with 13 Perth with Dr. Telly Tan.
Oh, wow, nice.
Yes,
And what's
yes.
the project relating
Yeah.
to?
Yeah. So we're going to link you much later, or anybody that's interested will post the poster when it's ready. Hopefully he gets the grant lah. Okay.
Nice. What is this project about?
We're going to do generative AI for young adults on the spectrum 13 to, I think it's 18, right, Alicia? I can't remember the details. Yeah. But MHI will be a platform to help. It's an ASEAN thing lah.
Very nice.
Good. Very
Yeah.
good.
Okay.
13 Miri has also just reached out to me that they're also interested in creating something for the autism
Great.
community.
So let them know. I will talk to you later. Then maybe
Yeah.
we can do something together. Dr. Amina, you there?
Don't see her.
Cursing,
Oh,
can you let
she's
her?
coming in. Yeah, I just let her in.
Okay, great. Put on your, yes, okay.
Okay. Does anyone else want to open their camera to join us? So
Yeah. All the others, anybody else? Okay, Cursing, you take,
Kasin, you need to open so Kasin.
Yes.
We
I think
don't
I'm
see
having trouble adding myself in, so that's okay. I will just let me check how can I do the gallery. Okay. All right. Okay, I can see everyone in the screen right now.
Thank you.
Okay, I will count to 3 from 1 and then we will start. Okay, 3, 2, 1. 3, 2, 1. Okay.
What about our other people who are left behind? Can we quickly take a photo too? Hi, the participants. Can you put your camera on?
I think
Possible?
Zamil just now. Hi, Zamil.
Ah,
It's me.
Hi, Isabel.
Hi, Alicia.
Hi, Isabel.
anybody else?
Yeah.
Okay, quickly
Teresa.
because we got to go. Oh, very
Hmm.
busy.
Wait.
Tak ada. Okay. 1, 2, 3.
Okay.
Kasing, you're there?
Yes, all right. 1, 2, 3.
Okay.
Okay.
Thank
Yes.
you so much, everyone. Okay.
Very much.
Bye-bye.
Congratulations,
you.
everyone. Thank you, Chingy. You did really well.
Thank you,
Thank you,
thank you.
everyone. Yeah.
You know, Dr.
Sure.
Lai, Eunice.
Bye.
Thank you.
See you,
Bye-bye.
Alicia.
Bye.
And Kasin, thanks so much. Yeah. Bye.
Bye-bye.